So we are now live with our 290th University of Best Practices that we've held since we launched the Right Care Initiative more than a decade ago. And we are just thrilled to be joined by participants from the state of California, the federal government. We have CDC with us, we have the National Institutes of Health with us, and it's been a wonderful silver lining in the pandemic to have the ability to bring in speakers from the national level as well as participants from the national level. So, and we can even work internationally, and one of our speakers is going to talk about that a little bit later today. So without further ado, I want to thank our leadership and our sponsors, which include our mothership, UC Berkeley School of Public Health, Center for Health Outcomes and Innovation Research, the California Department of Public Health, the Los Angeles Department of Public Health, Blue Shield of California, the Stroke Awareness Foundation, the multiple UCs, Stanford, and the University of Southern California, as well as the California chapter of the American College of Cardiology, and our wonderful biotech partners, Johnson & Johnson, Genentech, Novo Nordisk, Boehringer Ingelheim, Amarin, and Amgen, who represent the best of science. If it weren't for our scientists, where would we be with this pandemic? I also want to thank the Health Trust and the Community Health Partnership of Santa Clara County. With that, let's go to the agenda, please, Jenny. And I just want to briefly say how honored we are that we have the senior health scientist from Million Hearts, Hilary Wall, with us from the Centers for Disease Control and Prevention. We also have Dr. Jean Shahdadpuri with us, who after leaving Healthnet and Centene has gone on to work internationally with NICI, a global electronics firm. So with that, I'm going to turn it over to our dear chairman, Dr. William J. Baumer, cardiologist at UC Davis, and he is going to update us on the late-breaking evolution of the coronavirus variants. And thank you, Bill, for the extra work you put in to update us on what's going on.
Well, thank you very much for the introduction, and welcome everyone. We look forward to this program today with some great speakers that we have on board. Let me just check with Jenny. You have the screen from my COVID update on your screen, correct?
I cannot see your screen right now.
You cannot.
We are not seeing your slides,
Okay.
Bill. Why don't you just share screen with us?
Let's do it again. Okay. Share
so while
content,
Bill is working
screen.
on that, I will just say that I was reviewing data this weekend from Steve Sidney from the Cardia study. He's just publishing so much, and we can talk about that at the end in our Q&A portion if we have time. So we're seeing your screen now, Bill, and thank you for providing us with this update.
Well, welcome everyone. We're going to just briefly go through the waves of COVID at this time that have presented with the COVID-19 alpha variants, beta variants, delta, and lambda, where we are today. On the top left, you see the waves of the COVID virus, and we are now on the far right of that, approaching our fourth or fifth wave, depending on how you call it. Notice that this wave is going up very rapidly, certainly as rapidly as the January wave. And it's very likely that this wave will be as big or possibly exceed the January wave of infections and deaths that we had. potentially adding another 400,000 deaths, and some models 1 million more deaths to the US for it. And on the bottom right, you see that the US is heavily involved with now the Delta variant, as well as parts of Australia and Asia as well for that. So it started, appeared to start in India and rapidly got around the world for that. That's what we're dealing with. Why is it apparently more infectious? Well, the original virus seen on the top infected about 2.5 people for every infected individual. The Alpha variant was a little bit more infectious to the right at 4 to 5, but now the Delta shown on the bottom left, every infected individual appears to infect up to 8 additional individuals. So a lot more infectious. Measles is shown to the right. So you say if an R of 8 is where we are now, what's the maximum we can get to? We think the maximum is probably an R of 18, which exists for measles. So there's still ways to go for mutant variants becoming more infectious. The Delta does it by having a better spike that you can see on the left. It's more flexible, waves around, there's more of them, which allow it to attach to our cells through the receptor. On the right, you can see the receptor binding domain on the top of the spike binds to the ACE receptor. It's hidden by a lot of glycans shown in orange, so our immune system can't find it easily. So it's a more flexible, stickier barb that goes into our cells. So think of it as a super Velcro. Whenever it touches a cell, it sticks, binds, hooks into it. And by hooking into the ACE2 receptor, it allows it to attach. We manufacture our own enzyme, TMPRSS2, which actually helps it attach by cleaving the active site, allowing it to pull itself into the cell, our own cell, shown on the bottom right. And once it pulls itself, it merges the cell walls and then spills all of those viral proteins and contents and RNA into our own cells, turning our own cells into a production facility. The schematic is shown on the left, how it enters, turns our own Golgi apparatus into a production facility for the virus. In fact, the virus comes in and totally turns off our own model or our own system of manufacturing, converts everything in the cell to making new copies of the virus. Shown on the right is a picture of cells that have been invaded by the virus. Normally, a cell should have a single blue nucleus. Notice multiple nuclei all grouped together. It, in fact, destroys the cell enough that the cells merge with each other and form this super production facility, because all of the facility there in green is manufacturing new viral particles in a super plant that is multiple cells wide or thick, all glued together by this virus. So as we pursue the virus, we know that this virus has not only the ability for the Delta variant to manufacture more copies, perhaps 1,000 times higher level in the nasopharynx than with the old Alpha variety that we have, making it much more infectious, stickier so that it attaches to more cells easily, gets into the cells more easily. And this variant also appears to blunt the immune system so that we can't fight it as well. So this is becoming a somewhat super virus at this point in time. Our race on the right for drugs to control this is still limited, and we're still have a small number of medicines that appear to help it. And there are a lot of unknowns about this virus that are there. We do know that this virus affects over 332 other proteins in the human body, suppresses the immune system, totally interrupts and interferes with normal cell function at this time. These are guidelines that we have. Once you get infected, come into the hospital. We split up what we're going to treat you with various things, including supportive therapy, oxygen, mechanical ventilation, and even ECMO or extracorporeal membrane oxygenation when we need it. The medicines that have worked best and have been documented include the early use of remdesivir in certain individuals, but it has to be tailored to the right clinical presentation, and a later use of dexamethasone to suppress the overactive immune response, which can sometimes complicate this infection for it. This is the current treatment protocol, and this treatment has been successful in lowering the mortality for people in the hospital from about 2% down to about 1% with the old alpha variety for it. So very successful. But still, we don't have a way to cure COVID once it gets in the body. We hope that you do not succumb to the infection. So the best way is still prevention, and vaccination has been thrown out there. Vaccination has been very successful for this disease, but there's some concerns recently raised, and they include episodes of myocarditis or pericarditis after vaccination with this disease. You can see on the lower part of the column, those that get myocarditis are the younger people, 16 to 30 years of age, and they get it with their second dose shown in red on the graph. So those are the individuals who seem to have a tendency to get myocarditis after the vaccine. A little bit older people can get pericarditis as well for that. Is that something that you should avoid vaccination to avoid that? Well, probably not, because if we look at the numbers shown here, if you're vaccinated, your chance of getting myocarditis is about 5 cases per million. So fairly low. It's a low side effect ratio. If we look at individuals who do not get vaccinated, how often did they get myocardial involvement? Well, on the bottom right, you can see it's about 100,000 cases per million. So it's 20,000 times more likely you'll get cardiac involvement if you're unvaccinated than if you take the vaccination. So the odds clearly favor the individual who gets vaccinated. In addition to that, if you're vaccinated, there are no deaths that we have seen. And if you're unvaccinated, we're still looking at a 1% mortality and 2%. That's 10 or 20,000 individuals per million who will die from it. So if you want to avoid serious infection, death, and avoid myocardial involvement, you're much better off getting vaccinated than staying unvaccinated. If you want to travel, there's some recommendations shown here. Vaccination is clearly the first thing you need to start with. But because the new Delta virus can be carried by even vaccinated people, we're recommending that you, in addition, do double mask or an N95 mask for an additional 95% reduction. Practice social distancing. Avoid individuals who are unvaccinated. That will give you another 90 to 95% protection. Stay out of regions where it is high, such as Florida or Texas right now, and avoid areas where there's a high variant mutant that is present, which is more infectious, areas that are very high in new mutants, including Delta. Now, if you do all of those, you can see at the bottom, and travel and you're vaccinated, then your chances with the alpha variety were fairly low, 1 in 8,000. Now the Delta ups the ante, so your protection is not as great, about 1 in 800, but it's still pretty good to travel if you practice all of the things shown above on this slide. So in conclusion, the virus that we have, or the variants, are Delta, Delta plus, a little bit more infectious than Delta. Lambda is a new sublineage that has evolved. But even as we speak today, there are further mutations evolving around the world because so many people are infected and will develop mutations for it. So Delta plus, which is the stronger virus, already in Santa Clara County at 10%. will probably increase in California. Lambda is in Texas. B1621 is already in Florida in clusters. These are all very powerful or effective mutants for that virus. For those who have had vaccination, we still have pretty good protection with the Moderna, the Pfizer, and the AstraZeneca for that. But we do know with time, those antibody levels drop and the efficacy is somewhat less. So we're now talking about booster shots for the mRNA shots for that, and maybe hybrid shots where you would get one Pfizer and one AstraZeneca or something like that to give you more protection as we walk into the future with these super viruses that are there. We do know that Delta variant can infect the upper respiratory tract in vaccinated people, high enough levels that they can reinfect others even though they're vaccinated. The good news is the first 4 days, it stays mostly in the upper respiratory tract, takes longer to move on lower to get you pneumonia. And by that time, usually your memory B cells and T cells responses kick in, and they seem to protect you from getting pneumonia or dying from this Delta variety or variant, but they don't prevent you from spreading Delta to other individuals who were either non-vaccinated or had immunocompromised, so they didn't have an adequate vaccination for that. So I think we can, Jen, you can, I'll come off slide and we'll flip back to your presentation. I will stop sharing at this point, and we're going to proceed with the next part of the program, which we're delighted to have Hilary Wall here. As you know, we also deal and started out dealing with chronic disease, and chronic disease is cardiovascular disease, atherosclerotic disease. And Hilary is the senior health scientist for Million Hearts. Million Hearts was a very innovative program started years ago by the CDC, Center for Disease Control, to try to approach this chronic disease, knowing we had the ways to do it. We just had to implement those ways. And if we did it appropriately, we could save 1 million lives with that. And they had very good success early on. Janet Wright was the director for the program early on. And now Hilary is continuing to work on that as senior scientist, and she leads the Million Hearts Drive at this point in time. We're delighted to bring her here because she has developed and worked on effective systems of implementing preventive healthcare in the individuals in our ultimate goal to save 1 million lives. So Hilary, welcome to the program today.
Great. Thank you so much, Dr. Bomber. I really appreciate that. And thanks to you all for being with us today. I do want to just say that we still, while Janet Wright is not our executive director anymore, we have Dr. Larry Sperling, who has taken up the gauntlet and is leading us forward. I am the science lead for the initiative, but we've got just tremendous brains that are leading us. So it is truly my pleasure to be with you all today to discuss some innovations in hypertension control. I do want to warn you that I am an epidemiologist by training, so I've got quite a bit of data scattered throughout my talk, but it's really there to just help cement the fact that we've got some big issues to tackle together. So I'm going to start with the burden of cardiovascular disease in the US. I'm going to touch on the Million Hearts Initiative. Hopefully many of you are pretty familiar with it. Then I'm going to dig into the burden of hypertension and some strategies that we can employ to address it. And then I'm going to switch gears just a bit and talk about finding patients with potentially undiagnosed hypertension. Next slide. You are likely pretty familiar with these data. Every single year in the US, about 800,000 people die from cardiovascular disease and over 1.5 million have a heart attack or stroke. Disparities in cardiovascular disease are pervasive. It is actually the greatest contributor to racial disparities in life expectancy. And the resultant cost to our economy is large. We're at well over $300 billion per year spent in direct healthcare costs and lost productivity. Next slide. Overall, for the whole population, heart disease and stroke are the first and fifth leading cause of death, although COVID-19 may affect strokes placement in the leading causes of death. Those rankings of first and fifth remain true for men, but in 2018, which is our latest available year of death data, stroke was actually the third leading cause of death for women. Next slide. In older adults, the heart disease and stroke are ranked first and fourth as leading causes of death and are combined responsible for over 30% of deaths in people aged 65 plus and almost 40% of deaths in people age 85 plus. So again, tremendous contributors to the burden of death in our country. Next slide. And when we look at younger adults, yes, it's different. The picture is different, but for those who are youngest, ages 25 to 44, not surprisingly, heart disease and stroke only account for about 10% of deaths, 1 in 10 deaths. But in middle-aged adults, heart disease jumps up to be the second leading cause of death and is responsible for almost 25% of deaths in people 45 to 64. That's not so different from the data for people 65 plus. So this is definitely a condition that folks in that middle age group need to attend to. Next slide. Since the 70s, our country has really benefited from declines in mortality rates for cardiovascular disease, coronary heart disease, and stroke. You can see 1970s, it was sort of a steep decline. And then from 1980 until about 2010, it's less steep of a slope, but still nice gradual decline of cardiovascular disease death rates. But then we come to this 2010 time period, and it's a little bit hard to see on this graph, but it seems like the mortality rates are almost flattening out and possibly even little upticks there. If we go to the next graph, the next few graphs actually are from an excellent publication that came out earlier this year by David Goff and colleagues. They looked at mortality rates through 2018 and calculated what's called an annual percent change from year to year. They actually noticed a statistical inflection point in 2011. I sort of eyeballed it for 2010, but 2011 is when they really noticed it statistically, where the slopes of the lines changed. And you can see now, hopefully you can see the numbers on that slide, but cardiovascular death rates are just minimally continuing to decline. CHD death rates are still declining somewhat, but stroke is essentially flat. What I liked about this is the authors also pulled out death rates related to other heart disease, which is mostly attributable to heart failure. And those rates are actually on the uptick, which isn't surprising. There's unfortunately a tremendous burden of heart failure in this country. And next slide, we can dig into disparities in this data a little bit. On these graphs, you can see there's a pretty consistent mortality disparity for non-Hispanic Black men and women, who are the blue lines on all three of these graphs. And on the next slide, the disparity, if we start on the right-hand side, you can see atrial fibrillation, non-Hispanic white men and women are sort of above the pack in that graph. Heart failure, the middle graph, Blacks and whites are almost equal for death rates. But then look at that hypertension graph on the left. So this is hypertension related death. And you can see again, non-Hispanic Black and whites experience a disproportionate burden of deaths related to hypertension. Next slide. I also always really like to point out, we have a rural urban divide in this country. And that's true when it comes to cardiovascular disease mortality rates and many other conditions. And that's persisted over time, and it actually appears to have grown, with the blue line being more of like the suburbs. And you can see as compared to rural areas, that divide seems to be increasing. Next slide. But to be honest with you, the data on this slide are the ones that really keep me up at night. So I mentioned earlier that heart disease was the second leading cause of death for middle-aged people in 2018. This map shows county level changes in heart disease death rates from 2010 to 2017 in people ages 35 to 64. So heart disease death rates are on the rise for this population in 68.6% of counties in the US. And you can see it's basically from California to Maine. We don't just see it concentrated in the stroke belt. And the darkest red color is where we see 10% or greater increase from 2010 to 2017 in those death rates. So there's a whole lot of red on this map. And if we go to the next slide, you know, the visual picture, this is stroke death rates for that same group. This is 2010 to 2016. Visually, this looks a little bit better, but the death rate is still increasing in that same very young population across the country in over 60% of the counties. So next slide, the $1 million question is, why are we seeing these trends, right? So most experts will tell you it's due to the rising rates of diabetes and obesity that we've seen since the 80s and 90s. I don't disagree with that in any way, shape, or form. And that's really going to take like systemic change to try to stop those alarming trends in those conditions. But I would also argue that we have some acute opportunities to potentially impact these mortality trends. So a few years ago, we did an analysis on the actions that could impact cardiovascular disease, for example, statin use, blood pressure control. We then calculated the deficits. So for example, how many people had uncontrolled high blood pressure, uncontrolled hypertension. And you can see on this slide, these are the results, that there are over 213 missed opportunities for better management of cardiovascular disease and its risk factors. And what was most shocking to us is that over half of those opportunities were in that 35 to 64-year-old cohort. This is our workforce. These are our caregivers. We need, as a country, as a collective community, to do better. So next slide. In order to address this very large burden and some of the gaps in care, Million Hearts was launched. We are in our second iteration of Million Hearts. It is a national initiative co-led by CDC, my organization, and the Centers for Medicare and Medicaid Services, with the ultimate goal of preventing 1 million acute cardiovascular events, including heart attacks and strokes, in a 5-year period. And the sort of secret sauce that we think is there is we're trying to bring public health and healthcare together to address these gaps. On the next slide, Million Hearts aims to prevent events by supporting select evidence-based strategies in the 3 focus areas you see here: keeping people healthy, optimizing care for those who need it, and improving outcomes for priority populations. And when it comes to optimizing care for people with cardiovascular disease or risk factors, we focus on what we like to call the ABCs of cardiovascular disease prevention, where the B stands for blood pressure control. And we aim to achieve 80% blood pressure control at the population level, which frankly is quite the audacious target, especially if we go to the next slide, because we have a hypertension problem in this country. Almost half of adults have hypertension when we use 130/80 as our threshold. That is over 100 million people. And a very large subset of those people are recommended to be on antihypertensives and lifestyle modifications. And among that subgroup, 71% have uncontrolled hypertension. That equates to about 61 million people who are at higher risk of acute events. So if we go to the next slide, we can look at sex-related disparities in hypertension. They actually seem to disappear after age 60, the gray bars on this graph. Before then, men carry the disproportionate burden of disease. That being said, if you look at the third set of bars on the right, the second to right bar, you see 49.9%. 1/2 of women aged 40 to 59 have hypertension. That's 1 in 2 women in that middle age group. Again, our workforce, our caregivers. I cannot hammer this point home anymore. This is a problem. Next slide. We know that there are racial disparities in hypertension as well. I talked a little bit about deaths. This is prevalence. So non-Hispanic Black men and women are more likely to have hypertension than their non-Hispanic white or Hispanic counterparts. These data are not surprising. We know from the Cardia study, Hattie mentioned it before, that and other studies, of course, but Cardia to me is the one that really shown a very fine point on this. Non-Hispanic Blacks develop hypertension at younger ages and at more severe levels than non-Hispanic whites. So next slide is, this shows data that is similar to the one I showed earlier, highlighting disparities in hypertension-related mortality. But here we see those same data broken out by age group, and hopefully you can see this. It might be a little small on your screen, but we've got 35 to 64-year-olds on the bottom and 65 plus on the top. And in both age groups, Blacks have higher rates of hypertension-related death. But in that 35 to 64-year-old cohort, we also see a large disparity in American Indian and Alaska Native populations. So hypertension really just drives a lot of disparity that we're seeing in this country. Next slide. So these maps are similar to what I showed you earlier in terms of county level changes in death rates, but here we have hypertensive related cardiovascular mortality, and it's been stratified by Black and white populations. So again, the red indicates increases in mortality rates from 2010, and these are through 2019. And there is a whole lot of red on both of these maps. The gray on the left are suppressed cells because there aren't enough data. But where we see data, there's a lot of red. So increasing deaths, again, in that hypertensive related mortality. Next slide. So I know I have painted a fairly dim picture for you all with regard to hypertension in the US, and none of this, you were aware of all of it. None of it is really a surprise, I'm sure. But what keeps me going, what keeps me with Million Hearts, I'm now in year 12 with Million Hearts, year 11 with Million Hearts, but what keeps me going is that we actually know what works to improve hypertension control. We just have to figure out how to scale and spread those evidence-based strategies across the country. So since 2012, Million Hearts has recognized 118 hypertension control champions. This is a formal recognition program where we have self-nominated physicians, practices, health systems, or health centers. These are folks who have been able to achieve very high levels of blood pressure control. In the past several years, the threshold has been greater than or equal to 80% performance. There's a rigorous data vetting process that we do before we name someone a champion. And of course, we sort of interview these folks and we figure out, how do you think you've been able to achieve these very high levels of performance? And all of them have implemented some level of multifaceted approach that has included some combination of treatment protocols, team-based care, enhanced electronic health record functionality, and or free blood pressure checks. So that's sort of the high level summary. We know that these things work because they've been demonstrated in multiple places across the country. So how do we scale and spread? That's the real question. And on the next slide, it really thrills me that California alone has 8 of those 118 hypertension control champions, including 4 from community health centers, which is truly excellent. And I think there's only one state that might have more champions than California. So you guys, of course, are always the exemplars across the country. And on the next slide, the Million Hearts team took all of the wonderful learnings and resources that we could call from the published literature, from our hypertension control champions and other exemplars, and we turned into a product called the Hypertension Control Change Package. So if you're not familiar with that term, it's sort of a quality improvement jargony term, but a change package is really just a menu of evidence and practice-based strategies for changing a given care process. We've taken our change package sort of one step further than most, and we've carefully curated what we think are the best tools and resources for each evidence-based strategy. You can access that full change package at the URL on the slide, but I'm going to quickly walk you through pieces of it. So on the next slide, that hypertension control change package is broken into 4 focus areas. We've got key foundations where you'll find things like treatment protocols and info on office redesign. There's equipping care teams. This provides information on accurately taking blood pressure and establishing self-measured blood pressure monitoring programs, which we'll talk a little bit more about. Population health management supports using data to drive improvement and identifying patients with potentially undiagnosed hypertension. And then we have individual patient supports, which of course provide tools that set patients up for successful hypertension management. Next slide. Each of those 4 sections is comprised of change concepts. These are sometimes called key drivers, depending on what quality improvement framework you're using. These are really just broad categories for organizing change processes. And then change ideas are more actionable, specific strategies for change. And then we provide those tested tools and resources for each change idea that can be adopted as is or adapted for a given clinical setting. So let's review a quick example. Next slide. For population health management, let's say a health system decides it wants to use data to drive improvement. This is a personal favorite of mine. The quality improvement team decides to use quantitative data from their electronic health record to highlight gaps in care. And there are actually 2 aspects on which you can focus, highlighted in the change package. We've got determining which metrics you should use to measure the quality of care delivered, or regularly providing clinicians with dashboards or report cards. And the health system decides it has a need for a clinician-specific dashboard for care related to hypertension control. And then next, the change package then provides several examples of dashboards that have been implemented by real-life healthcare settings who have achieved very high levels of hypertension control. And they include a really wide array of graphs, charts, tables, there's spark lines, all sorts of wonderful things that you can choose from and adapt to meet a given healthcare system's needs. So that's how the change package works. One of the strategies that we highlight in the change package, as I mentioned, that really gets a fair amount of real estate is self-measured blood pressure monitoring, also known as Smbp, and I apologize, I will probably use the acronym. This is an evidence-based strategy for lowering blood pressure and improving control in people with hypertension. Self-measured blood pressure monitoring is the measurement of blood pressure by an individual outside of a clinical setting with a validated upper arm device that's ideally automatic. And it's sometimes called home blood pressure monitoring, but I really prefer the term self-measured blood pressure monitoring because it puts the onus on the individual and it also supports their measurement wherever they feel most comfortable. It's likely to be at home, but it could be at work, it could be while traveling, wherever they feel comfortable. When we talk about Smbp, it is not blood pressure taken at a pharmacy kiosk or with some of the new technologies that are emerging, like smartphone devices and others, because they're not yet highly validated methods of blood pressure measurement. They may be in the future, but right now, that's not where CDC is banking our money. So next slide. I'm not going to talk long about this slide, but there is strong evidence behind Smbp, especially when combined with additional clinical support. That is when it's incorporated into clinical care. We don't just want to tell everybody, hey, go get a blood pressure machine and you're on your own. That's not the point. So there are numerous systematic reviews and meta-analyses that support the use of Smbp with clinical support. It's been incorporated in different task force recommendations, numerous domestic and international clinical guidelines, and was highlighted as a major strategy for hypertension control in last year's Surgeon General's call to action to control hypertension. So next slide, let's walk through what optimal Smbp looks like. And this is really the Hilary Wall figure for optimal Smbp. So because the strongest evidence for Smbp exists when it's tied to clinical care, if we start in the green box, we want a patient with hypertension to be trained by their clinical team on selecting a validated device with a properly sized cuff, very important. We want them taught proper preparation and positioning for taking their blood pressure outside of their office. We want them provided with a clinical protocol with duration and frequency of measurement, as well as a method for returning those patient-generated blood pressure values. So ideally, those patient-generated blood pressure values would be returned in a remote fashion. That's not always the case. We're working on that at the national level, but it would become part of what I like to call a patient-clinician feedback loop, where the patient is at home, they've been trained, they go home, they take their blood pressure, they transmit those values and any pertinent lifestyle modification data that they need to get to their clinical team. The clinical team then interprets those data and sends back titration and or lifestyle modification advice, and the loop starts again. So that's optimal Smbp. Next slide. In that hypertension control change package I mentioned, there are resources in both the equipping care teams and the individual patient support sections that span the continuum of assigning care team roles, helping patients choose a monitor, developing a blood pressure loaner program, training patients, figuring out how to handle patient-generated readings, and then providing patients supports to successfully implement SMBP. Very quickly on the next slide, I've included a few additional resources from Million Hearts and our colleagues at the National Association of Community Health Centers, the American Medical Association, and the American Heart Association, because they all have some really excellent materials in this area for those of you who are interested. Next slide. And if you either are interested in engaging in SMBP with your patient populations or you're already working on it, I would invite you to join the Million Hearts Quarterly SMBP Forum. This is sort of a community of practice type webinar where we facilitate the exchange of best practices and provide members a place to ask questions and get answers. So our next call is scheduled for September 9th. The theme is going to be health information technology, and you can register via the instructions in the purple box on this slide. Okay, let's switch gears just a bit on the next slide. So over the years, and again, Million Hearts has been around for about 10 years, we have found, as we've been doing Million Hearts for a decade now, we've found these clinical settings who have been able to achieve high levels of blood pressure control. I've already talked through our champions, but there are many others. And as those clinical settings were doing that work to improve blood pressure control, many of them have discovered non-trivial numbers of patients with multiple abnormal blood pressure readings, but no diagnosis code. We have dubbed this phenomenon of potentially undiagnosed hypertension as hiding in plain sight. So on the next slide, I just want to bring us back to hypertension prevalence for a second. As you know, we're sort of in this country currently living in a little bit of a limbo in terms of threshold for hypertension. Much of the work that I'm going to review with you was done before the ACC-AHA guideline came out in 2017. So I'm going to be using 140/90 throughout all of this work, but it can be adjusted to 130/80 very easily. So what's consistent, and you can see the data are pretty consistent on these slides, regardless of what threshold you use, hypertension is a highly prevalent condition, and it's more prevalent in some of the subpopulations, like the elderly and like non-Hispanic Blacks. We've already talked about this. Using 140/90 as a threshold, about 1 in 3 adults have hypertension, which equates to about 78 million people. Next slide. Of those 78 million people with hypertension, about 35 million of those are uncontrolled, according to data from, this is the National Health and Nutrition Examination Survey, or NHANES. Right now, people who are aware of their condition, so the orange and blue pieces on this pie chart, despite their treatment status, there are evidence-based interventions that are known to improve blood pressure control. We already talked about SMBP, there are many others. But the group that I want to focus on today are those who are unaware of their condition, this 12 million or 11.5 million cohort that you see in gray. These folks in NHANES report having never been told by a doctor or other health professional that they have hypertension and are not using blood pressure lowering medications, but they have measured high blood pressure. And I think it's really easy to assume that these people are among the uninsured population who do not access the healthcare system and have consequently not been provided an opportunity for detection and diagnosis. But I am a data-driven person, and if we take a closer look on the next slide, we're going to see that over 80% have health insurance, over 80% report having a usual source of care. And I previously said that, we've got this 12 million people with uncontrolled hypertension that are unaware of their condition. Here, my third bullet point, we're showing 63% of that 12 million have received care 2 or more times in the last year. So just that subgroup alone equals over 7 million adult Americans who are regularly accessing care, but the opportunity for hypertension diagnosis, treatment, and control is being missed. And this is worth our collective action. But I keep talking about surveillance data. You're all a bunch of clinicians. Let's delve into how all of this translates into the clinical setting, because that is very important. So Million Hearts and a number of quality reporting initiatives like the CMS merit-based incentive payment system, we monitor the quality of care delivered by clinicians to hypertensive patients using a clinical quality measure known as NQF-18, sometimes called CMS 165. They're all basically the same measure. And they look at the percentage of adult patients who had a diagnosis of hypertension using ICD-10 codes, whose blood pressure was adequately controlled. Again, we're still using this under 140/90 threshold during the measurement year. So in order for a patient to be included in this quality measure, they must have a diagnosis of hypertension. They have to have that ICD-10 code. By default, clinicians are judged on how well they control high blood pressure among diagnosed individuals. So these measures overlook the potentially undiagnosed hypertensive population, and I want to show you why that can be really important. Next slide. So this is what I like to call a little Hilary math. Let's take a practice that has 100 adults, 1,000 adults, whatever number you want to pick. I'm using 100 so I can do the math easily. 100 adults with diagnosed hypertension, if 70 of those adults have their most recent blood pressure under 140/90, then that practice has a 70% blood pressure control rate, which we should celebrate, right? Next. But if we take a closer look at their patient population, what if the practice has 50 patients with multiple abnormal blood pressure readings, but who have not yet been given a diagnosis code for hypertension? If we include all of those patients in our measure of blood pressure control, it has a potential to have a real impact on control rates, here dropping from 70% to 47%. Now, obviously, that's the worst case scenario. It assumes that all 50 of these patients are, quote unquote, hiding in plain sight, that all 50 of them definitely have hypertension, but that may not be the case. But this phenomenon is real. Again, we've seen it documented numerous times in healthcare settings, and it's definitely something that we need to pay attention to. So if you go to the next slide, geez, it's been almost a decade that we've been talking about this, but back in November of 2014, we, the Million Hearts team, published a viewpoint in JAMA that summarizes what some large health systems have done to address this phenomenon. And as we were doing the research for the viewpoint, we pulled out common themes from the published literature. And these included using data to determine if a practice might have undiagnosed hypertension, setting definitions for a patient with potentially undiagnosed hypertension, exploring electronic health record data to find patients who meet those clinical criteria, and then implementing a plan to confirm whether or not those patients have hypertension. Next slide. So I've given this talk many, many, many times to different clinical populations over the years. And I often hear people say they don't think they have a problem with undiagnosed hypertensives, or they've never thought to explore it. And it's really the latter that I want to draw your attention to. So I said earlier that 31% of adults in our country have hypertension. I would encourage you all, if you haven't done so, just calculate the prevalence of hypertension in your adult population. You can do that. I've given you the equation on the slide. You just divide the number of adult patients with a diagnosis of hypertension by the number of adult patients and multiply that by 100. If your calculated prevalence is much lower than that US prevalence of 31% or so, you probably have patients who are hiding in plain sight. So next slide. One question that I often get asked is, what clinical criteria should we use? Just tell us, how should we look for these people, and we'll move on with our lives. Well, unfortunately, there really isn't one great answer. To search for patients who might have undiagnosed hypertension, I recommend that the clinicians from your healthcare setting develop what I call clinical criteria to summarize how they would define a patient with probable hypertension. This should be based on the clinical guidelines supported by your practice. You can work with your team to determine the number of elevated readings and the degree of elevation that should trigger inclusion of a patient in this group of potentially hypertensive people. You just really want to pick what works for your practice based on your available resources and capacity. Next slide. Once you've got those clinical criteria established, you then need to figure out a way to apply them to your electronic health record data. And all of you, I know this is very hard, much easier said than done, and you could all give me a lecture on how best to do this. The ways that I've heard clinical settings be able to do this are through registry functionality that would allow you to generate sort of a customized query. You might be able to use various population health management software solutions, or if you're lucky enough to have sort of informaticists on staff, programmers, they might be able to do some savvy programming for you. Next slide. Once you have found a group of patients who may have undiagnosed hypertension, I then recommend you establish this care pathway for confirming whether or not these patients do indeed have hypertension. That can include a number of different things. I've put a few on this slide: 24-hour ambulatory blood pressure monitoring, ABPM, self-measured blood pressure monitoring, which we talked about, Smbp, or automated office blood pressure machines, AOBP. You could also use just really accurate repeated office blood pressure measures. And if you click once, the first two on this list are, Jenny, can you just click once? These first two are recommended by the US Preventative Services Task Force and the 2017 ACC/AHA guidelines for confirming a hypertension diagnosis. But other practices have had great success using these AOBP machines as well. So once you confirm the hypertension status of that group of patients, you could then start that cycle that I just went through all over again, using different clinical criteria, sort of relaxing your clinical criteria, if you will. But on the next slide, before you start the cycle again, if you don't do anything with the patients who you found the first time you went through that, and you determine that they do not have hypertension, they're still going to have this pattern of elevated readings. And if you don't do anything to them, they're going to end up when you cast your second net finding people. So what some healthcare settings have done is they've assigned ICD-10 RO 3.0 to those people. That way they can exclude them when they do this exercise again. And I also know that some healthcare settings have used that ICD-10 code to pull a customized report so that they can follow these people sort of after a year's time, just to make sure that they're still doing well and have come back in for a recheck. So next slide, because all clinicians they're probably the most busy people I've ever met. I recommend, as you undertake this work, that you start small with what I like to call conservative clinical criteria for finding potentially undiagnosed hypertensive. So for example, look for patients with one blood pressure value that's very high. Use, say, greater than 180 or greater than 120 diastolic, right? So hypertensive crisis. Do you have any patients who ever fit that criteria? More conservative criteria like that, the smaller circle on my diagram, they are more likely to have what's called a higher positive predictive value, or PPV, which is really just the likelihood that the clinical criteria will correctly identify patients with hypertension. If you have a higher PPV, you won't be wasting valuable resources bringing back in for confirmation large numbers of patients who don't actually have hypertension. So once you've explored your patient population using the conservative criteria, you can loosen them up a bit to see if you can find additional patients. So maybe you go to that next circle, the next largest circle, 160 over 110, for example. So next slide. In our hypertension control change package that I mentioned earlier, again, there's a whole section dedicated to helping to find patients with potentially undiagnosed hypertension. And Jenny, just give a quick click. This section of the hypertension control change package directly aligns with that 4-step process I just reviewed. And just for the record, there's also a section for finding potentially undiagnosed chronic kidney disease in patients with hypertension. So next slide. You know, today you've got the CDC figurehead, talking head, whatever, talking about what seems like a theoretical issue, but this is a problem that healthcare settings have demonstrated in the published literature and beyond. So I just want to take a few minutes to review some of their real life experiences, because there are lots of pearls that we can pull out and take away from their work. So next slide. Just very quickly, all the published studies that I'm going to go through revolve around the researchers wanting to explore hypertension more broadly in their patient population. And all of the researchers developed a slightly different, what I like to call a hypertension phenotype, that basically how could they observe people with potential hypertension in their electronic health record data. It could include obviously diagnosis codes, but also patterns of abnormal blood pressure readings, as we've been talking about, sometimes presence of antihypertension medication prescriptions, and sometimes free text notes as well. So they all built this group of hypertensive patients using those aspects of a potential hypertension phenotype. Next slide. So we start very quickly with North Shore University Health System. They wanted to explore, they wanted to eliminate undiagnosed hypertension throughout their primary care network. They were lucky enough to have informaticists on staff, so they embedded algorithms, the ones that you see on this slide, right into their electronic health record to identify patients. They then implemented a diagnostic protocol that utilized an AOBP machine, automated office blood pressure machine. They happen to use BP True, and they verified whether or not patients flagged by the algorithms actually had hypertension. The take-home message here just reiterates what I said to you not too long ago: start small, because that one that I have circled in red on the slide, they looked at one value greater than 180 systolic, greater than 100 diastolic, and they found over 500 patients just using that one algorithm. So if you start small, you're going to find people. Palo Alto Medical Foundation in California, they assess patients with 2 or more abnormal blood pressures, an antihypertensive medication prescription, or both, and found that almost 40% did not have a hypertension-related ICD code. So when they included some of these patients in their prevalence calculation, it increased by 10 percentage points. So that was my point with the Hilary math before, that you really do have more patients but if you're only using ICD-10 codes, you're going to miss some of those folks. So really important aspect to this study was that they statistically found you were much more likely to be on an antihypertensive prescription or medication if you had an appropriate diagnosis code. So for them, diagnosis often equaled treatment. Next slide. Researchers from the University of West Virginia again explored hypertension in their electronic health record. They used the sort of phenotype you see on the slide, diagnosis code, 2 or more abnormal readings, and they used free text data entries. And they found that 13% of patients across 11 different health center sites did not have a diagnosis code, but had one of those other 2 criteria. And I think it's important to note from this study, because 13% doesn't seem so terrible, but they had a wide range. Some sites, it really wasn't an issue. They had a range from 4 to 48%. That means at least one of their sites, at least half of their patients did not have a diagnosis code that were likely hypertensive. And next slide. Researchers from the University of Wisconsin, and I am trying to go quickly because I know I'm approaching time shortly. They again assessed undiagnosed hypertension, but they were really focused on looking at young adults, because data from NHANES showed historically that younger adults as compared to middle-aged and older adults had lower hypertension control rates. So they followed cohorts over time for 4 years, and it showed that the younger adult group was much less likely to receive a hypertension diagnosis than older adults, even when they had those elevated readings. And I totally understand that, but I just showed you all a whole boatload of data that showed increasing death rates and numerous missed opportunities for better cardiovascular disease prevention in younger adults. And I understand the hesitation from both clinicians and patients with starting a young person on antihypertensive medications, but the prospect of having them have an acute event should outweigh that hesitation. So next slide. But published studies for CDC, they were great, but we really wanted to understand how the sort of sausage was made, if you will. So we actually partnered with the National Association of Community Health Centers, who brought on 10 federally qualified health centers to look for potentially undiagnosed hypertensives. They went through that whole 4-step process. Their prevalences were low. They developed clinical criteria that you see on this slide. They used population health management software to find people who were potentially undiagnosed. And they took all of that work and they created a change package. Again, URL is on this slide. You go to the next slide. These are some of the data from this project. So these 10 health centers over an 18-month period found 8,600 potentially undiagnosed hypertensives. They were able to bring back in for confirmation about 5,600 of those patients, and almost 1,800 of them received a hypertension diagnosis for a positive predictive value of 32%. Now that's a little bit lower than I think most of us would like if we're bringing patients back in for confirmation. But again, if you looked at the clinical criteria on the previous slide, they cast a very large net and tried to bring back in a large bolus of those patients. So next slide. We have been very focused on hypertension. And I mentioned earlier about finding people with potentially undiagnosed chronic kidney disease. But this kind of data exploration can really be used for many different conditions. So for example, again, we looked at national surveillance data. We looked at adults who were eligible for being on a cholesterol lowering medication according to the 2018 guidelines, excuse me. There were about 28 million people who were recommended to be on a statin but weren't. These high-risk individuals might benefit from additional clinical attention. So we took that surveillance data, we partnered again with a bunch of community health centers, and we searched their electronic health record data using the clinical criteria in the 3 boxes across the slide. These are the 3 highest risk groups of patients: those with clinical ASCVD, those with LDLs greater than 190 mg per deciliter, or patients with diabetes. And we just looked to see whether or not they were on any statin at all. If a patient in any of these groups is not on a statin, it may warrant additional clinical attention. That's the whole point here. And then if you click one more level, if you want to get a little fancy, you can then, even among the people who were on a statin, you can just look to see, are they on atorvastatin or rosuvastatin, the only 2 high intensity statins. If not, again, additional clinical attention may be warranted. So great quality improvement opportunity here, and very applicable to other conditions as well. Next slide. So I just presented you a lot of data. Jenny, you can turn one more slide. A lot of data, a lot of information, probably too much, but I would be really happy to take any questions if you have them. I haven't been monitoring the chat as I've been talking. If we have time, but always feel free to email me if you have any additional questions as well. So thanks so much for your time and attention.
I believe that Dr. Baumer will be moderating your questions and probably has the first question for you. And leadership and all of our participants, please put your questions in the Q&A while we proceed for the next 10 or 15 minutes with Q&A with Dr. Wall.
Hilary, that was a fantastic presentation, and we've all been impressed with the efforts of Million Hearts, from Janet to Dr. Sperling. One of the things that you're showing, and effectively, is the so-called surrogates, the blood pressure, the cholesterol improvements, and things like that. But Million Hearts' original goal was to save 1 million lives, I assume, in 5 years. Is there a way to measure that? Have you found a way to see if your influence, that is the lowering of blood pressure and the control of cholesterol, has actually resulted in a numerical or a statistical reduction in mortality in those groups, or is that just too hard to approach from a statistical analysis and public health?
So it is an excellent question. What we have done, and it is complicated. I mean, you can imagine. So Million Hearts, yes, we're focused on blood pressure control, cholesterol management. We have other aspects in the platform as well that I didn't really touch on: tobacco cessation, community-based strategies. So, and we've been taking this in 5-year chunks, again, to try to take a chronic condition and give it an acuteness, right? So we're trying to prevent 1 million acute cardiovascular events, some deaths, but some hospitalizations, some emergency department visits. There's a publication that laid out our surveillance methodology where we have a whole algorithm of getting mutually exclusive, again, deaths, hospitalizations, and emergency department visits using a very specific case definition. And this case definition consists of the kinds of, we call them Million Hearts preventable events. They're the kinds of cardiovascular events that we think our actions could potentially prevent. So congenital heart disease is not going to be on that list, right? It's a subset of case types. So we've got that all laid out in surveillance methodology. And then for the first iteration, we set a baseline. There were a couple different ways you can do it. We've got that all laid out. And then 5 years later, we calculated, okay, how many events, we predicted how many events we thought there might be, and then we calculated how many events actually occurred. And what we found is in the first 5-year iteration, we believe our collective impact was to defer 135,000 events. May not seem like a win, but we sort of knew that the million was going to be very audacious. That was like a stretch goal to get people motivated. And I would say, well, 135,000 events, that's the people who didn't have those events, I'm sure, are very happy about it. And we calculated, I think it was $5.6 billion that wasn't spent as a result of those events. And then we're finishing up the second iteration of Million Hearts right now. Unfortunately, because of the data sets that we have to rely on to do that calculation, we won't have final results for the second iteration of Million Hearts probably until 2023 at the earliest, because death data in particular has a long data lag. But we definitely were on top of it. We plan to calculate it. So there is a peer-reviewed publication, and then we also have those final results. The 135,000 are in a final report that's on the Million Hearts website, and I can send you all this information if you're interested.
Well, thank you very much, and congratulations on those lives saved or deaths deferred at that point. In our chat box, we had a couple of questions. One was, do you get involved with comorbid conditions that might be, let's say, leading to hypertension in individuals, including substance abuse or the cofactor of tobacco or stressors in life? Does that something that you get into, or is that just too hard to look at confounders of that condition?
No, another great question. So we really do. We understand it's easy for us when we're communicating to talk about blood pressure control, cholesterol management. We're really talking about comprehensive cardiovascular disease risk reduction, right? And that is multifaceted. So tobacco plays a really key role. Physical activity plays a key role. We're trying to reduce sodium intake. And then within subpopulations like Blacks and African Americans, for example, we've been working to address hypertension in particular with them through federally qualified health centers, but you really need to attend to more of that holistic approach as you're trying to control hypertension. So yes, there are definitely other aspects in there. To be frank, the socioeconomic stressors, we haven't attended to that. Moving forward, you know, we're about to launch. So at the end of 2021, the current iteration of Million Hearts comes to an end, and we're going to be relaunching a third iteration of it. We're carefully thinking right now about how to attend to health inequities. And some of that is the social determinants of health. So we're trying to figure out right now, how do we move more into that space, because it's clearly so important, especially to some of these disparate populations. And I do want to stress there a great part in here. Million Hearts has focused for the last 5 years on tobacco use in people with mental health and substance use disorders. So we have another change package. I focus all on the hypertension control change package. We have a tobacco cessation change package that has very specific strategies for behavioral health settings, because the rates of tobacco use in that population are twice that of the general population. So it's all in there. I just didn't have time to address all of it.
Perhaps one quick question before we move on is self-monitored blood pressure. Great, you know. How do you propose that the cost of that be covered? And is there a plan to get coverage so that patients will get reimbursement for obtaining that? Or how do we distribute the self-monitored blood pressure cuffs in a cost-effective way and an affordable way for many of these individuals who may not be able to afford that, or it's a stress to pay for it?
I'm so glad you asked that question. It's, I swear, it's almost like I gave you that to ask me. So I could give you an hour-long answer about that. I'll try to be brief. So
take your time, Hilary.
Okay.
We really want to hear this one, and we're
Okay.
not shifting speakers for another 5 to 10 minutes.
Okay, great. Then I will tell you about this one. So yes, in SMBP, clearly, device coverage is of utmost importance, as is reimbursement for clinician time. I just laid out on that ideal, optimal SMBP slide, all of these things that we want the clinical team to do to ensure successful SMBP implementation by patients. That's a lot of burden on clinicians. We need to reimburse them appropriately. So the American Medical Association created 2 brand new CPT codes. I'm, of course, forgetting the numbers because I don't talk in codes, but I can get the information to you very easily. There's 2. In fact, there's a link to one of the AMA resources in my slide deck on SMBP CPT codes. 2 new codes. One is to reimburse the clinical team's time in a one time to train people basically to use home blood pressure monitors. And then there is a recurring monthly code that can be reimbursed for physician time to receive the readings, interpret them, and incorporate them into the care plan. So 2 new codes. I will tell you, we did a quick analysis from last year. They were just introduced at the beginning of 2020. We looked at the surveillance data from Medicare, fee for service, and they're very underutilized. So we need to spread the word that those codes exist, especially with the pandemic. I think it's really, really important because all of a sudden nobody was going to see their clinical team in person and there was no blood pressure data. So we need to get those codes in use for reimbursement. Then on the coverage side, we've done a Medicaid analysis. Obviously, that Medicaid population is really key for SMBP. We've got preliminary results from that. And I think it's on the order of 32 different states have some level of coverage for SMBP devices themselves. I say some level of coverage because, again, we're digging into these details. It looks like in many cases, it's insufficient coverage. So it's one thing to say the state of X provides coverage for SMBP devices, but when you look, it's $9. And oh, by the way, an average home blood pressure machine that's automatic, that has Bluetooth capability, that can store a number of readings, that maybe has 2 different profiles if one family wants to use the same device. So the average machine costs $50 to $100. And then on top of it, again, data, when we looked at NHANES data's about a decade old, but they measured people's arms, their arm circumference for people with hypertension, and found, I think it's 50% of men with hypertension and 38% of women with hypertension need a large or extra large cuff. And that is different than the standard adult cuff that many of these devices come with. When you look at the cost of, say, an extra large cuff, and we did this again as part of the work we were doing with federally qualified health centers, who 50% of their population needed an extra large cuff, those devices, especially if you're getting like clinically validated devices, which we didn't get into, but they can cost $100 minimum. So we're introducing even more disparity here for the populations that need these devices potentially the most. So this is all stuff that's way on our radar screen. I also want to say, we are hoping that Medicare at some point in the future may cover home blood pressure devices, to be determined. Groups like the American Heart Association and the American Medical Association are spearheading work in that area. And interestingly, I think it was last year, possibly the year before that, no, I was working on COVID, I think it was in 2020, CMS published a federal register notice on what they called their blueprint for value-based insurance design, right? They listed 10 services and medications that they considered to be high value, but underutilized. And home blood pressure devices were one of those services. And their recommendation to plans that were on the marketplace was that they cover those devices for free. So never mind coverage, just give them to people for free if they have hypertension. So we're trying to, even within CMS, like connect all of those dots. They're giving other insurance providers recommendation to just cover them for free, but fee for service doesn't yet cover them. So there's just a little bit of disconnect, but I couldn't agree more. These devices need to get in the hands of the people who need them the most. I know that some federally qualified health centers in particular have started device loaner programs This is so that, healthcare setting, the health center, they buy a whole bunch of devices and then they loan them out to patients. And there's a whole process you can put in place. I've got those resources highlighted in our change package. But like that's a workaround that some places had to come up with because these devices are cost prohibitive for many patients. So sorry, I could keep talking about this forever.
So Hilary, I just want to do a quick follow-up on that.
Yeah.
And really thank you, Dr. Sky, for reminding me about that value-based question, which is the graphs you see behind me here are how quickly we dropped acute myocardial infarction hospitalizations by giving intensive sort of quality improvement support, including showing the medical groups in one community their data on a monthly basis for the three metrics of the Right Care Initiative that we focus on, which are blood pressure, blood sugar, and cholesterol control. And what we found, both in our American Journal of Managed Care article, which is right behind me, is that particularly for women, we dropped the hospitalization rates quite rapidly relative to the state. So that's the aqua graph there. We also dropped it relative to the state for men, the acute myocardial infarctions. And also there's graphical data that shows the mortality dropped, as you would expect it to in the same parallel fashion. In addition to reducing the events from those three simple metrics, and we were using 140/90, we also are documented as being associated with saving $86 million from those fewer events. So can you help us think about, or can you be the one that really tries to drive the fact that we would save billions across the country if we just get those three things done? So in the metric system that we have, we know that the medical groups and health plans are inundated with all the different measures they have to cover. What if we just stopped for a couple of years and said, let's do these three. Let's get this right. Let's teach all the medical systems to know how to manage the number one killer and disabler. And we would save the nation not only money, but we would save families like mine from the devastation of losing loved ones due to preventable events. So let you answer that. And then Jenny, please put up Dr. Jean Shahdadpuri's bio while Hilary gives us a quick answer on that.
I mean, Hattie, I think you're spot on. Unfortunately, the clinical quality measure space is one that has a lot of external influence. We have worked hard in Million Hearts to at least keep the ABCs measures, including blood pressure control and cholesterol management, statin use. We've worked really hard to keep those in CMS programs and other quality reporting programs. But you're right, the field is flooded. And I think that there are ways to get them upweighted, which we have done in Million Hearts. We could do a better job of that. But I think I always say, like, I'm not a good salesperson, because to me, the data speak volumes. The data I just showed you all, it's like mind blowing to me, but to other people, cardiovascular disease, not sexy. Nobody cares. So we have to figure out a way to get people to care about it. And we need a really good salesperson. Maybe you can
Let's work together.
Yeah.
I will go anywhere. I will talk to anyone. I am so passionate about this. Like you, it wakes me up at night. Yeah. The opportunities for protecting patients, even, if we think about it, the incidental coronary calcium, if we're not going to do the direct coronary calcium scores, which I strongly believe we should be doing at a regular schedule at least once. And I would say for all 45-year-olds, and I know those aren't the guidelines. That's what I believe based on my family experience and the experience of the people around me. But if we're not going to do a direct one, why aren't we at least requiring that when we have incidental findings of coronary calcium, that we do something about it? Put those people on statins. So yes, I would be happy to testify. I would be happy to do op-eds with you. And I'm so thrilled to have met you. So I want to introduce you to another major woman warrior in the space of improving cardiovascular outcomes. Many of you already know Dr. Jean Shahdadpuri because she's spoken to the Right Care Initiative now for about 5 years. My favorite time when she presented was when she brought her father over from Dubai to be with us at our summit when we were meeting in person. So I should say that Dr. Shahdadpuri has some great news for us that she mentioned during our Women's Cardiovascular Disease Writing Group a few weeks ago, and we asked her to present on it today. And that is that by aggressively pursuing the goals of the Right Care Initiative, her company really saw a lot of savings, both in terms of events and dollars, just like we saw on a community level in San Diego. So with that, I'll say that she can't have done this for 28 years because look how young she is. But she's had an amazing career, and we knew her as the Senior Vice President for Medical Affairs at Healthnet, where she was in charge of pursuing the Right Care goals under the orders from the state of California for quality improvement among multiple health plans. So with that, let's also just give her kudos for being, as many physicians are, also a musician. So she plays the sitar and she's a scuba diver. And these are things that we find actually fairly common among our physician leaders. So great athletes, great musicians, great minds. And with that, let's pull up Jean's slides. And Jean, thank you so much for all the effort that you made to pull these together and for your great leadership at Healthnet Centene.
Thank you, Hattie. It is such a pleasure to be back. I did relocate to UAE, Dubai, at the beginning of this year. As many of us realized when our families are abroad, how important it is to cherish time with them. The whole family unfortunately did get COVID, but they were just fine. But it just was a harsh realization of how we should be spending quality time with them. But having said that, I loved my time here. It's lovely to be back in San Francisco. It has such good energy despite the fires and the COVID. It has such good energy of fighting back and continuing to move on the good stuff. So my career did start with Stanford. So this was always my home. And then I moved on to Kaiser, that actually trained me into a very structured way of thinking and documentation with their electronic medical record. I think they were one of the earlier ones to start, and they were trying to incorporate a lot of guidelines and systems and structures and documentation so that the physicians don't forget or go in a very structured, consistent manner with each patient, how to monitor all the vital signs. And so from paper charts to electronic medical records was our first revolution, which I think would help a lot in our blood pressure and other vitals monitoring. From there, I did have the privilege to do a lot of good work with Centene Corporation, which is now a $115 billion corporation, and I worked with their health plan in California called Healthnet of California, which you all might be aware of. And this was one of our initiatives that showed very good results. And I just wanted to share the success story with all of you, hoping to expand this and scale this at any level in any geography, because it would yield results wherever this is followed. So I can start now. This is, again, presenting the results of what we did in Healthnet with all the lines of business across the state of California. Okay, thank you. So just to give you the landscape of California, about 12.4 million Medi-Cal members, dual eligible, which are Medis at 1.1 million, Medicare at 6.4 million, and commercial insured patients at about 11 million. With the structure in California as such, we have health plans, we have fee-for-service providers, and then we have capitated medical groups. A large part of California is under the capitated medical groups that submit their encounters, if not claims, to get reimbursed for the care. Next. We followed, keeping the member in the center, we followed an integrated multidisciplinary approach. As we know, the community around the member, their providers, their benefits that they have in the health plan, their mental health plan, everything works together to control the chronic diseases that they have. We try to integrate physical health, behavioral health, pharmacy services, and ancillary services. I think somebody asked a question in the last presentation about did other factors contribute to the African American to be higher incidence of these chronic diseases like mental health issues, etc. And I feel if you look at a person as a whole, they have we may look at them as a number or a blood pressure number or a cholesterol number, but they are a whole personality that might have a lot of other comorbid conditions or other conditions that we do need to address if we are trying to make an impact in their chronic disease state. So we have, luckily, we had a very comprehensive set of benefits that we offered for the members that included the prevention, health and wellness, pharmacy, specialty pharmacy benefits, dental, vision, pre-COVID, and then it took off during COVID was the telehealth services, which the organization was very active and very proactive in launching these services, making them accessible to all the physicians that were struggling to keep their doors open or maintain continuity of their patients. We have a whole suite of in-home services that had providers going out to these members' homes and checking on their vitals and checking on their conditions. We have care management, case managers that do a very, very good job with our chronically sick and high-risk population. And then, of course, we have the behavioral health and specialty programs. So we kind of made sure that each of our intervention was addressing all these other services that we offer. Go ahead. As we know, as Hilary presented, I think Hilary's data was impeccable. She's shown the numbers, which are pretty startling. And we all know that we've always looked at higher age groups, a high-risk population with chronic diseases. However, what I notice is the middle age group now, both the genders, more African-American than other ethnicities, are high risk for heart disease and diabetes and hypertension. What we did was we took the highest risk population of our organization that had diabetes, hypertension, and chronic heart disease. And about 183,000 of those members was our cohort, and we tried to implement some kind of intervention around this cohort to see where the gap is. So when we were in our data analysis stage and pulled up the data of which member was on what medication, we noticed that 40% of this population was not on the basic cardioprotective bundle. And for all those who don't know what cardioprotective bundle is, it's just aspirin, statin, and antihypertensive. So the basics, it doesn't cost much. The cost of a cardioprotective bundle is less than $5. And so we found that this 40% of the population wasn't on any medication that was helping them get better. Next. So the idea of starting this, as Hattie said, was the state requirement of undertakings that we had to make an impact in the quality initiatives with our high-risk population. The study that triggered this initiative was initiated at Kaiser Permanente, where they looked at about 170,000 individuals over 2 years. These were individuals that either had diabetes and were older than 55 years or had cardiovascular disease, which is prior heart attack or stroke. And they were put on aspirin, a statin, and an antihypertensive. Now, they divided it into 2 groups. One was the low exposure group who was on the cardioprotective bundle or medication bundle for just less than a year, and still found an impact where 726 fewer heart attacks occurred. So approximately 15 per 1,000 members did not have an hospitalization because of a heart attack or stroke. And the high exposure, which was members who were on the medication bundle for 1 to 2 years, also had 545 fewer heart attacks and strokes, which means 26 per 1,000 members. Now, when I read this study, it was so impressive that I actually got in touch with the founder and started talking about how has it evolved over a period of time. He was very upbeat and said it's still going very strong, and this is definitely impactful. So next slide. What we did was take this as the base study and took all the population with our with Healthnet, who had diabetes over the age of 55 and was high risk because they either had hypertension or a previous history of heart disease. Next. So this was our SHAPE model, and which is stroke. So we coined this term, stroke and heart attack prevention every day, which is what SHAPE stands for. So Hattie there for the acronym, check. We took all our patients that were over 55 years old with cardiovascular heart disease and hypertension. Now, difference between all study and this was we took the population that are all 3 comorbid conditions because they were definitely at the highest risk. And like Hilary said, we always wanted to start small. I wanted to start a pilot to show an impact, which was a quick win, something that you could address quickly to prevent anything from happening to these highest risk population. And then we, instead of specifying what aspirin, what brand, what dose they needed, we pretty much left it open to they should be on aspirin, a statin in the category of statins, and an antihypertensive without really focusing on the actual brand and the dose. And then we put a whole structure of infrastructure of people around these members with our healthcare coaches that were comprised of diabetic educators, nutritionists, dietitians, even engagement by these healthcare coaches on site at the physician's office or telephonic. And the frequency of engagement of our coaches was calculated by the equity and the risk of the member. So this was our model. We covered all of California. We covered all lines of business. This was actually a little bit of a struggle to do because each line of business has a very different reimbursement model, and it was expensive to do this for all the lines of business. However, for a physician who's seeing 100 patients a day or a week, I did not want him to differentiate between an X and a Y. If their patient needs and has a need for intervention or a need for support with our resources, I wanted it to be very clear that the physician can just take our resources and deploy to any patient of his or hers. Next. So we had short-term goals and long-term goals. Of course, that had KPIs attached to it, ROI attached to it, and savings. Short-term goals was just to partner with our providers and provider groups and health systems, share what the best practices of care were, to stress and show them the data that in a physician's office, how many members of theirs weren't on the cardioprotective bundle at all or were on partial cardioprotective bundle. And if they were put on the medication, were they compliant and adherent to the medication, or did they just drop off, not taking the medication for any reason? We wanted to then educate the members and the providers about their medication and wellness regime, and then share resources for the physicians and the members to get back on the medication bundle, to clarify any questions they had on the medication bundle. Our long-term goal, of course, was to decrease and prevent cardiovascular events in this highest risk population, to educate them about their disease. Now, I can't say enough about this. If the member is educated about why they need to take an X medication or Y medication, why they need to be following a lifestyle modification, why do they need to be following a diet or an exercise regimen, they have to understand their disease state. And healthcare coaches are the ideal workforce or provider giver who then can work with them at their pace in their language on why all this is necessary for them. I feel once the members are bought in to why they need to do XYZ, they feel they're not regimented, and they kind of incorporate a lot of things in their daily lifestyles. Of course, overall aim was to go for the quadruple aim of improved population health, improve member experience, lower the costs, and improve the provider experience. Next. So these were all the supporting activities that we kind of started or launched to support the providers and the members. So data was our backbone. That's the biggest green box. Data was our path or light to go forward to how do we address this population. When we got this list of high-risk members, we were shocked. The first year we started, this slide deck is about the third year that we presented. The first time we ever touched this population, 67% were not on the cardioprotective bundle. 67%, and these are, like Hilary said, they're insured, they've met their caregivers, and they've been receiving care one place or the other. Well, so that was shocking, but even more motivating to do something about them. Now, we had online tools. So My Strength is a member online engagement platform, which works on their own motivation on weight loss and exercise and wellness. By the time I had left, My Strength had also gotten into their mental health field, where we address depression, anxiety. Just to give you an example, if a patient is depressed and doesn't take their antihypertensive or their anti-diabetic medication just because they were depressed, that would lead in the deterioration of their chronic condition. So they're very interlinked. Unless we address their mental health or physical state, we should not expect them to get onto the medication and the better health state. The quality improvement part of it was the visibility to the physicians and the physician groups and the healthcare systems as a whole on how their population stood in terms of certain quality metrics or HEDIS rates. HEDIS covers a lot of the blood pressure, diabetic measures, and hypertensive measures. So the report card, not just the dashboard, but with the ability to go drill down to each member to see when the last care was received, when the last lab was done, when the last hemoglobin A1C was done, and what exact medications are they on. So we worked a lot on the platform or the report cards that were given to the physicians and the physician groups to know exactly in a glance 100 of my patients are on aspirin and statin, but not on a cholesterol drug. Or I had put them on a cholesterol drug, but after 6 months, I don't see them on the cholesterol drug anymore. And so it made it very easy for the physician to then delegate the lists of these members who had gaps to get in touch with them and bring them back in, or talk to them and get them back compliant on the medication. We had a lot of clinical program managers who are very, very, very qualified to do this. They are from the healthcare field, so they're either nurses or MPHs. They would make these report cards along with the resource package. So Hilary called it change package. I love that. Just resources package, and what help can a health plan give to the provider and the member to take charge of their health. We had different regions of California that we divided into 6 regional medical directors who were then leading the initiative with each physician and provider group to make sure these care gap lists were addressed. So if you have Dr. X and Dr. Y that have 100 members that are not on the cardioprotective bundle and their HEDIS measures are lacking, then they would drive that initiative and improvement and monitor it every month, giving support with the clinical program managers, even weekly if needed. We had case managers that would talk to the members or to the clinic to explain to them what programs we have and how do we get them enrolled. We have Healthnet clinical pharmacy team. Now, this was very interesting. We involved a lot of pharmacists, about 28 of them, who then reached out telephonically to the members after seeing these care gap lists, asking questions like, hey, we do see a prescription of statin that you started on, but we don't see it refilled. Was there any issue? Was there any hurdle in you getting it filled? Are you having any side effects? And a lot of the feedback from the members where they were just confused. They would have gotten hospitalized. They had a pink pill instead of a blue pill, instead of a brown pill, and they just stopped it because they weren't sure what to do with it. Or they double dosed on it, which was even worse. So the clinical pharmacists took their time to explain to them interactions, side effects, why they needed to be on it, even titrate the medication if needed for hypertension, of course, with the keeping the PCP in the loop, keeping their own doctor in the loop. We involved a lot of disease management vendors that worked with us very, very closely. So we have Optum, we had Omada online coaching program. And then we have involved pharmacy solutions. That's our pharmacy division of the organization, that we started dispensing Bluetooth enabled glucometers and blood pressure cuffs to the highest risk patients. And last but not the least, it was the electronic pill box. A lot of the times so this was all around medication adherence and compliance. If you have somebody who has dementia or is just a senior member and is having trouble in taking the medications, we gave them electronic pill boxes that would trigger a text message if it's not been opened for that day for the 2 p.m. dose. And would say, hey, would you like to check if you've had your medication? Hey, would you like to see what your sugar is so that you can get to that medication? This was a good idea and a good concept. Somehow it didn't catch on to a lot of members. Not sure why, but in concept, I thought it was a very good concept. Next. So results, the proof is in the pudding. It can't be all talk. So within a year, we actually saw a significant decrease in the utilization, which means hospitalizations that were related to heart attacks and strokes. Now, Hilary talked a little bit about the codes, but we had very clean data because we had a very competent team where we actually had our cardiologist doctors there pull up the list of codes that were specific to stroke and heart attack. So it wasn't birth defects or some other diseases. It was just purely heart attacks and strokes. We found that the patients were very engaged, hence satisfied with their care and involved with their care a lot more. you'd be amazed how much patients appreciate this engagement, and they actually stick to the health plan, which was a good thing to sell to management about the retention. But if the patients find that the health plan cares for them or their doctor cares for them, they generally stick to the plan. We had a high cardioprotective medication bundle adherence rate. So we went from 67% not being on the bundle to now 43% that were not on the bundle. Our PMPM, which is per member per month cost, decreased, having a lot of cost savings. So that was different by different lines of business. Our highest impact was in the Medicare line of business, which was reduced by 60%, Medi-Cal reduced by 27%, commercial reduced by about 17%. And to quantify that, next slide, we actually had a decrease in the heart attack. So this is a big news line, breaking news, something that the marketing team picked on, but it involved a predictive modeling. So we took the same cohort of members that were in the program and their past trends of how often were they hospitalized for heart attack and strokes. And then we compared them to being after the program of how many heart attack strokes did not happen. So it's a predictive modeling. But we did do it on the same cohort, pre and post the program after 1 year. And we found that we had already decreased heart attacks from 1 in 4 to 1 in 6, which was for me very rewarding, because it's 2 lives that have a better life, that have less disability and are alive and educated now. So now my focus was, how do we make this sustainable and how do we scale it up? We also saved millions, to be exact, north of something like 10 million for 2 consecutive years. So it wasn't just the low-hanging fruit on the tree. It was consistently year after year, north of $10 million savings, which means lesser burden on the healthcare system, apart from the other benefits that are to the member. Better quality.
Before you move on, can you elaborate a little bit on how we can encourage the other health plans and health systems to save this money and save these lives? Because why not? Why would you proceed with status quo if it costs you less to do the right thing?
So true. So we did have Blue Shield do a very similar program, also achieve very good results. Scott Flynn is on. He was our colleague. I hope other health plans caught on. However, health systems have caught on to this. So UCLA, UC system as such, Sutter, they started taking this program and started saying, hey, Jean, we would like to have our own pharmacists reach out to our own patients or our own case managers. And so I did allow flexibility in whatever model they wanted. My focus was, who is the best person who has a relationship with the member, who would have the most impact and engagement. And a lot of times it was their case managers or their pharmacists. The pharmacist's role was key in not only engaging the patients, but also interacting back with their PCPs or cardiologists or endocrinologists, saying, hey, did you know, we talked to the patient and he's on these 2 medications and we just recommend you that the dosage should be changed or it should be titrated. In addition to the lot more time that this provider, the pharmacist or the coaches could give to the members off hours, during work hours. So the engagement was just so much more tighter than what you have in a physician's office in a 10-15-minute visit. And I think that's getting very, very obvious now. The pharmacists are getting into a big expanded role, which I'm hoping will really lead to the extension of the physician services to the members. So we had also things like feedback that came back from the members saying they haven't been absent from their workplace. So I'm sure there was more productivity, they were more productive citizens, there was better economy, could definitely use that in these times, and lesser disability and just better quality of life. So these were our results. Next slide. Quality improvement next. So a lot of health plans focus a lot on the quality measures. Now for them, this is a report card that need to be check-boxed, and the physician or the provider group actually gets measured against this dashboard or report card and could get a different rate of reimbursement for their patient care. So there's a lot of focus and work always going on in this area. So of course, we use this opportunity to incorporate whatever we were doing to drive the physicians to work on these measures that would also impact our Right Care initiative or the SHAPE program. So we have measures like blood pressure, eye exam, diabetic control, hemoglobin A1C testing, nephropathy, which are all diabetic related measures. And then of course we have certain hypertensive related measures. Now, the different colors are the different lines of business. And what this just showed us in 2019 is that we actually managed to make an impact in getting all these measures to reach 75th percentile, or even more than 90th percentile. So wherever you see the 2 check marks, they've gone beyond 90th percentile. And wherever you see a single check mark, it's beyond 75th percentile. So this at a glance told me in all the regions, in all the lines of business, that there was movement happening in the right direction. And my goal was to fill everything with double checks. Next slide. So these were the opportunities for improvement. So it's funny, when I did show this report card to a lot of the provider groups, they started getting very competitive because it was one provider group against the other. And it was hilarious how they came up with things like, hey, Jean, we just missed it by 0.5 percentile. Can we get this checkboxed? And so I did include that for groups that had just missed it by 1% or less, and gave them the black check. So it does show, just this report card shows the amount of engagement that each region had in all lines of business on these measures. So the fact that you focus their attention on these 3 conditions and focus on the 3 medications, and they're getting better by showing more adherence, their hemoglobin A1C is getting better. Just the fact that this report is checkbox, you know this patient population is going to do better. So this was very, very good, very rewarding. It's kind of like I haven't gotten as excited to see a report card like that since my 10th grade. So this was wonderful. All right, next. Now, these were all the HEDIS measures that were getting impacted by our intervention, which means that there was that much more motivation for the provider groups to get engaged with our SHAPE program. These are the measures where they get rated. They actually, as I said, the revenue depends on it. And a lot of the times in our case, we actually gave them a whole bunch of incentives based on the performance on these 6 HEDIS measures. So that was an additional lever that we pulled to get more and more engagement from the provider offices to help these members. Next. This was our outreach strategy. Like I said, we had multimodal communication. So the one thing we noticed about engaging a member is that they would like to get engaged at any hour, on any day, by the person of their choice, for the time duration of their choice. And this cannot be forced on them. So we started expanding the avenues that we were engaging with them, which was either a mail or an IVR call that was more and more tailored to being more like human interaction. text messaging, online newsletters, letters, emails, live calls by appointment by the coaches and the pharmacists that were actually trained in motivational interviewing, which basically just means don't push the member if they don't want to be pushed, just take it as they want to go. We gave a lot of incentive programs, both to the physicians and the members. In-home visits, which was key because a lot of the members had stopped going and visiting their physicians. So in-home visits where this could have been achieved in their own setting, in their own comfortable setting, this was very helpful. Provider outreach also involved a lot of visits from our team, which is our CPMs and regional medical directors, with the care gap list, with the report card, with the, like she said, change package or our resource package that we took in a lot of the joint operation meetings. We rewarded them for good results, and then we put them on extra monitoring and tracking if the results were lacking. Next. These were some of the tests that we incorporated, which were more self-administered. So everything that helped them to do at their own time in their own comfortable setting. And this was helpful because they were testing their hemoglobin A1Cs. It's pretty much like how Hilary said, if they're self-monitoring their own vital signs or blood pressure, they just seem more aware and more conscious of what they're supposed to do. So this was a very good program where they actually had to just assess their values and then send the envelope back to the agency. Next. Medicare line of business, we had a one-stop clinic program where the health plan actually supported them financially and resourcing with staffing to extend their clinic hours. So if the patient cannot show up in the regular working hours, we extended hours up to 7 p.m., sometimes up to 9 p.m., where these members, specifically these members, could make appointments to see a physician or a care provider and get all their gaps addressed. So get their hemoglobin A1C, get their blood pressure monitored, get their eye exam, get their kidney function tests, etc. We also did a whole bunch of on-site, like I said, in-home visits that included MedXM. It's just one of the vendors that helped us visit the members in the regions that were difficult. If you remember, there were California fires in many of these regions and they could not get to their provider offices. And this team was critical in showing up at their homes and providing them either medication or just testing or advice and checking on them. Next. Member incentive program, we did incentivize the members with gift cards to go even have a visit with their provider, or to do these 3 measures, which was hemoglobin A1C testing, to get their eyes checked and to get their kidneys checked. And then we incentivized them to be engaged to better their health. Next. For Medicare, we had toolkits, multiple tip sheets, best practices for the provider groups to kind of be more aware of what we had to offer. Next. This was a large employer group, a pilot project that is now an inherent part of how they treat their patients. So we started sending newsletters out for diabetic along with ADA collaboration. There was another custom toolkit, which was Let's Be Well, that kind of focused more on diet, wellness, exercise, hydration, stress relieving, and then, of course, the AHA blood pressure guide. Next. American Heart Association also collaborated with us wonderfully. We participated in their program that monitored the participants to commit to improving high blood pressure and reduce number of heart attacks. This was also very successful, and we were one of their preferred partners in this program. Take charge of your health was probably the most effective program when COVID started, because this was more online, engaging the patients with very simple screens. I put the pictures of the screens on the right just because they were not cluttered, they were not busy. It was easy to follow. It was more like smiley faces of how are they feeling today. And you'd be amazed of how isolated these members felt during COVID, in quarantine, not being able to visit their provider and be in touch with their regular routine and regimen, getting medications. So mental health component played a big role in maintaining chronic diseases. And I cannot stress enough how mental health addressing comes prior to what you want to do for chronic disease management. This was very helpful, a lot more enrollment during this time. Omada was our partner. That was, again, an online self-management platform where the diabetics, obese patients with some history of cardiovascular disease got along with their peer and got onto a 16-week program or a 17-week program where they would discuss about, hey, I went for a trek. Hey, this is my diet plan. Hey, this really works. Hey, try these recipes. So it was less intimidating because it was more amongst their peers, however, led and monitored by a health coach for support and motivation, making sure the conversations are going in the right direction. Next. We had a lot of wellness webinar series. I'm sure by now thousands of members have engaged in these wellness seminar series. Next. This was an interesting program where we started just with the Medi-Cal population. So we took the highest risk list of members and we started engaging with them with the coach, and then started asking them, hey, how would you feel if you had a cellular enabled glucometer, which means you'd get a trigger to check your sugar and the data would get transmitted to an electronic device of your choice. We would monitor the data 3 times a day on a daily basis, unless we see a value that's out of line, and you would get a message back saying you need to repeat your blood sugar level or your blood pressure level. And then if that is again out of range, you would get on the phone with a coach. Now we had a hierarchy where they would talk to the coach first, then it went to a nurse if it was something serious, and then it even went to the PCP or an endocrinologist if needed, of course, then to a 911 call. However, this was very helpful because we were tracking the big data with a team in-house, and that got in touch with the members only when there was something wrong going on. So it happened a lot during the holidays when the sugar levels were all out of whack, but at least there was a continuous monitoring, and the member felt, oh my God, I'm gonna get a call from my coach, so I better go down on my cake or whatever it is. So this was very helpful. It was cellular enabled, so there was not much of manual work. We have now gone to cellular enabled blood pressure cuffs and weighing machines. So this is very good intervention. Next. This was, like Hilary said, start small. We focused on ethnicities playing a role with medication compliance. And there was this one set of population that whatever we did, the rates plateaued or even went worse. We narrowed it down to a small Chinese-speaking population in San Gabriel Valley in LA. This is the population that was going and seeing their doctors not that frequently. However, the prescription claims kept dropping in between. On looking closer at this group, we found out that they believed in a lot of alternative medicines, which was supported by their providers. And so they were tending to stop their statin and go to something more herbal, something more natural. And hence we never got the claims. Now, what's even more interesting is they thought this was helping their blood pressure and cholesterol, but it wasn't in their labs. A lot of them didn't even get tested, so they they didn't think there was a need to get tested. When we did urge them to get tested, we found the data was not to their expectation. And so the providers needed to be educated to kind of look into the alternative medicine alternatives. Not that they all don't work, but there are definitely some that didn't do what the desired goal was. So this was a good intervention. It was a small population with a small provider group to address, and we addressed both the members and the providers, and actually now the rates have started to look better. Next. So this is just a list of all the initiatives that are being done, which I described in detail. Go next. Jenny, if you could go to the next slide. Okay, so this is the commercial population and their 3-year trends. If you go next. Again, individual measures, different line of business. It shows you in green what did go up, and then in the black that didn't go up. So these are a lot of numbers. I think you can keep going. This is just visually easier to see what's going up, what's going down. The green is good, red is bad. Next. This is for the Medi-Cal population and their trends for the last 3 years. Keep going. Keep going. Next. And this is for Medicare and their 3-year trends. Keep going. I can skip through these slides. Okay, so this was interesting. It was kind of what Hilary showed as well for hypertension. This is for diabetes, and we noticed a lot of high concentration of diabetics around LA, San Diego, and Fresno area. Fewer in the Bay Area. However, the population was very concentrated in the Sacramento region. Next. Majority of the diabetics over 55 came from Imperial County. Again, the darker reds are the ones where they were highly densely populated. And this goes to show either an ethnicity or a provider shortage or just access or awareness issues amongst the population. Next. This was our disparity reduction project that won an award in Boston. This was around the Chinese population that I described earlier. Next. This was Population Health Awards. I mean, these were the little awards that actually give a lot of motivation to the teams to know that their efforts are being rewarded. I used to make sure that some of those people are going to receive the awards in Washington, Boston, because it gives them such a fulfillment sense on what they've been doing matters and what they've been doing is recognized. So going to next steps and know that this is a model that works and it is a success story. I wanted to brainstorm and throw some questions with this intelligent audience on how do we expand and scale this program up, either geographically or do we focus and target our attention on certain ethnicities and go small, like Hilary said, and then take care of their cultural sensitivities? How do we measure the impact of all our efforts? Now, it took a lot for me to do the predictive modeling and actually see the decrease in the heart attacks. Usually it's not that easy to come up with results and KPIs that you need to have a whole dedicated team working on the data. How do we fund a lot of these initiatives in other states or in other parts of the world? And then can we get not a cookie cutter model, but something that's consistent guidelines and processes to ensure that if that's implemented, you will get the desired outcomes, like, or it's more reproducible from our earlier initiatives. I have moved to the UAE, and it's not surprising. They have 17.3% of their population that's diabetic, some 43% that's obese and suffer from hypertension. The rates are higher in women than men, maybe because of their sedentary lifestyle. However, what I'm finding now in the cultural sensitivity piece is the woman is the caretaker for the entire house. And so if she herself is having a lot of these comorbidities, what initiatives, what kind of diet, what kind of groceries, what kind of lifestyle is she propagating to the next generation, so this doesn't keep going on. So that's where I'm focusing my efforts in the Middle East. Every region has its own uniqueness. However, it's very important that we design something that's impactful to every member of each culture and ethnicity. So I'm hoping to partner with Hattie on figuring out a model that works in the UAE, where I can hopefully present some results in the next 2 years to show how it's impacted. And I think that's pretty much the last slide. That's my contact email. Would love to get your feedback and questions. And Hattie, if you're open, Wayne had a question that is in the Q&A section that I can address if you would like.
Absolutely, yes. We would love to have you answer as many questions as people want to stay for. And excellent presentation, fantastic work. It must be very fulfilling to see the number of fewer heart attacks and strokes and the cost savings. There's Dr. Flynn coming on to ask a question. So let's have him unmute himself and verbally ask.
Hi, Jean. Congratulations. Great results. Well done. 2 quick questions for you. And I think you kind of answered one already, and the other one you probably said and I just missed it. How did you get providers to buy in? Was there some kind of provider incentive for these, or what was the secret sauce that you used to get providers to buy in?
So I just said, if you don't listen to me, Scott's coming after you next.
Okay, so what was the real tactic?
So the real thing was this. It was a combination. One, if you tell a doctor that he works 8 hours a day, 5 days a week, and 100 of his diabetics, out of which 50 are doing badly, and they're not on the basic medications they should be on, I don't think any provider takes this well, right? The next step you do is show them comparative report cards between them and their colleague or another group in another region. And this gets them going. But honestly, they all want to do the right thing. They all want to take care of their members. What happens is when you were seeing 8 patients, 10 patients a day on an appointment basis, on a sick visit basis, it doesn't occur to you to zoom out and see how are all their diabetics doing, or hypertensives doing, or even their asthmatics doing. And so this is the report card we showed. We gave them support, active support. So not just going there, showing the report card, but actually coming up with, hey, what should we do? This is the plan. Here's where our team will help. Here's our pharmacists can help call your members. Are you open to that? And then as the progress starts and the good results start, I think then they get really into it. And then, of course, I wasn't kidding when I said, if all the other health plans work the same way and want the same thing from the provider, it is going to hit them that they need to take care of that population better. Wayne had a question, Hattie. He's saying, based on the data of primary care providers sufficient to screen and manage hypertension and its associated comorbidities, is it a workforce capacity issue? For sure, a provider office on their own cannot manage all the things we want to do in that 15-minute visit. So our role as a health plan was to give them that extension, that collateral support at the pace the member wanted, at the time the member wanted, and for the duration the member wanted. And that's where the healthcare coaches came in so handy. Now, they're not as expensive as physicians, However, they were very effective in a very non-intimidating way to engage the members and get them to buy into their plan and care plan and management of their chronic condition.
Right. So it sounds like you did the same thing we do is, hi, this is an issue you should care about, and here's the data that supports it. And by the way, you personally aren't doing as well as you think you are. And we actually have some ways to help you. We're not just asking you to do more. We're going to show you how we can help you. And that's a great way to get by. And the second question I had was, how is it being sustained now going forward? And do you know if there's future plans for expansion or going in different directions?
It is what I talked to some of the colleagues. I think population health is gaining a lot of momentum, and pharmacist role is being seen as key. So lesser of nurse management and provider management, more of pharmacist or healthcare coach management. What they're getting into now, I think, is more remote devices and analysis of the big data. What took momentum, I think, last year from COVID was mental health aspect of it, which I'm so happy. It takes a lot of moving mountains to get mental health data incorporated with the physical health data, and the providers to interact and work with each other. So to that extent, I'm sure there's a lot more work left, but at least it's an initiation in the right direction with that.
Great. Congratulations again, Jean. Well done.
Thanks, Scott. So good to see
I
you.
see we have cardiologist Evelyn Stock on video here. Evelyn, did you want to ask a question? If so, please unmute yourself.
Hi, Jean. That was a fantastic presentation. I am so curious to know when you were sending out these communications to your members, were we included? Was UCSF included, or was it directly to certain medical centers? How did you go about selecting where to send these, and how could we get on
So
board?
we were flexible. So what we did a lot of was offering. So if a provider office cannot afford to do something like this, we said, here, take it. Somebody like UCSF or UCLA said, no, we already text message our members. We would like to incorporate our own language, our own way to interact with the members. Just get us the data or the lesson. That's what we did. For sophisticated systems that are already engaging a member with the same platform, we actually had a long Excel sheet running where I wanted to make sure we're not overlapping or double dipping on what they're doing and just confusing the member. So starting from a PCP to the physician group, we were continuously working with them to say, would this work? Is this something you'd be interested to take on? Or are you doing something of your own? And a lot of the health systems had a lot of their own mechanisms to do that, and we continued that way. Like I said, sometimes they had their own pharmacists or case managers, their own texting platform that they used. Some were very integrated with the EHR of the physician, which worked even better for us. So the point is, you don't want to do an abrasive way of engagement. You just want to do it right enough and do it with what they would want to be engaged in. If you lose their interest, it honestly, it's nothing a provider can do to get them better.
So I have a question, and then I'd love to have Dr. Balmer ask a question, because he's always got questions. How did you address getting the self-monitoring devices to patients? As we were talking about with Hilary Wall of Million Hearts, we need patients to be doing self-blood pressure monitoring, etc. So how were you able to fund that? And then were you able to take the savings that you recognize? I think you said $10 million on our women's cardiovascular writing group. Were you able to take that savings and then expand the program with that savings?
So that's exactly what we did. The first year we had savings of just under 1 million. The second year was when we saw traction, and we got into the phase 2 of actually getting into cellular enabled glucometers. But you're right, the organization has to be proactive and be ready to reinvest some of that to scale it up, and to be innovative about it. So the whole 28 pharmacist program was stood up with some of the savings, the devices. Now, of course, each part of this involved a lot of negotiation. We luckily had a division in our own company that could actually source the devices maybe cheaper than what they would get in the market. We subsidized the cost of the devices just because we anticipated savings. So it was a lot of effort in maybe planning and making this program sellable. So if you just took the cost of the devices and put it on the patients, that wouldn't work. So that's good thing that you work for health plans that have a little deeper pockets and believe in wellness and prevention, so that you can make these programs feasible as a win-win situation.
So did you start this program before the Department of Managed Healthcare required you to improve your metrics on cholesterol, blood pressure, and blood sugar, or was it a response to the requirement of the state of California?
It was a bit of both. There was a lot of stuff going on, a lot of communication going out to the members, a lot of scattered initiatives everywhere. But when somebody got you to focus it and started monitoring a set of population on a set of measures, then of course the focus becomes on getting programs more structured, maybe more enhanced, targeted to getting results. There was definitely an impetus with that, and thank God for that, because it definitely got us in the right direction.
I'll be talking with the governor's office on Thursday, so I might mention this.
Oh, this is wonderful. I mean, I just think, you know how they say the right bang for the buck? Usually with all the good intentions, you have a lot going on with a lot of people. And sometimes mailers and things like that just aren't impactful enough. So just to make sure that that dollar is working for you and the member, that's what it takes to just get the focus in a structured program. That's what this did.
Wonderful. Well, I think your talents brought to the cause were just immense, and I appreciate it. Go ahead, Bill.
So Jean, very great presentation, and remarkable the implementation and the effect that you had. I was totally impressed by the fact that in 1 year you had a 24% reduction in events relative, and an 8% absolute reduction in events, which is actually better than we have in many of our controlled trials, where we have individuals, closely monitored in controlled trials. And it was in year 1, which is faster than what we've seen in some of our cholesterol reduction trials, et cetera. Were you surprised to see such a benefit in such a short time, like a year or two? I mean, that's remarkable.
Yeah, so of course, the first year I feel is always easier to achieve because it's the lower hanging fruit that you get. So that was more of, oh, oops, the prescription has been sitting there. Oops, I didn't get it filled. I didn't know what this was and started taking it. The physicians just looking at that report card and calling them made a lot of the impact. The higher hanging fruit was more how to get them to stay on it. We found it was difficult for even physicians to start doing statins. I mean, they would sometimes drop it or drop the dose and not be on the right dose just because of the side effects. The pharmacists actually played a key role in talking to these providers and doing something called a re-challenge test, where they suggested the recommended dose, maybe a different brand, to see if the side effects went away. So the higher hanging fruit was definitely in year 2, year 3, but each year you would have to do something innovative. and tougher and more relevant to get additional savings. But yes, the initial year where the 67% were not compliant with the bundle, that was challenging. We knew aspirin is something that doesn't get captured in the claims, and it's over the counter, so we weren't necessarily getting that data. That data was just something that we got telephonically with the members, but just to get the message out to CVS and other pharmacies we work with on the necessity of them being on aspirin. It was a lot of initiatives, I think, that went to community health workers that were visiting homes, talking about these medications, the in-home physical exams, the guys who were now talking about the same thing. I think it's a lot also when two people tell you the same thing, you maybe tend to think about it more than before. So it was just like Hattie said, more focus, more emphasis on repeating what the patient needed to hear.
Do you think that the bundle, bringing them into the bundle and then showing the patient individually their success rates with, let's say, cholesterol and blood pressure, really encourage those patients individually to become more responsive for their own healthcare? And perhaps you've got synergy of bringing the patients into the fold of compliant patients across the board.
I agree, Bill. Honestly, the benefit was coming in patients just knowing that they're feeling better. They were feeling more active, more healthy, less hospitalizations, better work attendance, more aware of what they needed to do, when they needed to do. So just the fact that they knew if I don't do my sugar 3 times today, I'll get a call tomorrow. So they did it, and they knew what to do with those sugar levels or their blood pressure levels. They were asking more questions. I think just to get the patient at that level will probably win half your battle.
Mm-hmm.
I see that Wayne Chen, I don't know whether he's still on with us. We could promote him to panelists to ask him to ask it, but he's wondering if your results are published and what the plans are for publishing it.
I had plans of publishing it. There was a team actually working on the publishing. I don't know if they ever got to it, Hattie. I would have known about it, so I think that might have gotten left off.
So we have quite a bit in the chat. Are you able to look at it? I'm just trying to interpret this question. Bill, you understand the SGLT2s and the GLP-1s. I don't know what ENVOLVE is. Dan
Involve.
Huberty. Yeah, it says, I was wondering if you had any knowledge of involved similar initiatives supporting Healthnet patients that went a step further for those with diabetes and cardiovascular disease, utilizing the newest medication guidelines, integrating the SGLT2s and the GLP-1s. There's more there, but
So
we'll start with
just
that.
in short, yes, Involve is a subsidiary of Centene Corporation. So they were our partners. They're the ones who've been working with us on that same cohort.
So can you just address the piece about guidelines integrating the SGLT2s and the GLP-1s into treatment? Did you do that? Was that part of the success you saw? Because of course we see really significant drops in event rates with that, wonderful new addition to the armamentarium.
I believe that is incorporated in the program now, Hattie. However, I can't be too sure.
Let's see, do we have other questions that have not been answered? I don't want to keep people too long. We're now, we're at about 2:30. So I think what I'd like to do is just encourage you, Dr. Shahdadpuri, to work with your colleagues to get that published, because I believe the health systems are more willing to try something if they see that someone has been successful at it already.
Evidence-based literature, absolutely. Absolutely. I shall work on that.
And hopefully today, the Million Hearts might look at this as a premier example in a large group, ethnic group of success early on that could be perhaps used to scale up nationally for this.
And I see our wonderful Albert is reminding us of our next university best practices. It's actually, there's a typo there, sorry. It's Tuesday, August 31st, not August 30th. So it's always the last Tuesday of the month when we gather. So we gather on the second Monday of the month at noon and the last Tuesday of the month at 4. And that program will be magnificent as well. We will have Katrina Taylor from the California Department of Public Health, the lead epidemiologist, updating us on what's happening in a more granular way in California. Then we will also have the health system, Palo Alto Medical Foundation that Million Hearts highlighted, talking about a special program they're doing for their diabetics who have cardiovascular disease. So that will be EdU and Dr. Mehta together from Palo Alto Medical Foundation. And then we'll also have a report from the Office of Statewide Health Planning and Development of the state of California on preventable hospitalizations among diabetics. So we have a wonderful semester of programming coming up, and what a wonderful kickoff to our second semester here with Dr. Jean Shahdadpuri and Hilary Wall from Million Hearts. So Jean, I just encourage you to keep your hand in healthcare. Don't get too distracted by your company business. You have such a gift for this work, and so many patients need you. Our population health space really needs to learn from your experience, and hopefully you can find someone else to run NICI while you come back to healthcare and put your considerable muscle into that.
I am already putting something together in that region. It's a unique region. I feel there's more difference to be made there because it's not as structured. People aren't as aware of the basics. There's so much stuff out here available. There's not much over there. So there's a big opportunity there, probably something that should be addressed sooner than later. So I am looking forward to putting something together.
Wonderful. So we have many of the women on with us right now that will be reconvening for our third meeting of the Women's Cardiovascular Writing Group this Wednesday at noon under the leadership of Dr. Noelle Barrymers. So with that, I'd just like to invite you all to join us on Tuesday, August 31st at 4 p.m. And a big round of applause for Jean, and thank you so much.